And I also believe that their dedication to this work has really been helpful, and there is a community of practice. If anyone is interested or wanting to know more, please visit the University of Victoria's site. They have a community of practice. They have tons of different information sessions. They help each other out. We send emails to each other to get ideas or overcome some obstacles. So to them, I say many, many thanks. And I have borrowed some information from them, and have definitely used them in the development of our program. So a quick outline of what I hope to get across is just a review at what managed alcohol is. I'm not sure where everyone's understanding is. So just a general overview of MAP, how MAP aligns with our goals in our agency, the development of our program in the Battlefords, our challenges, we've had many, but we've also had many successes, our current status, which is up to date as of last week, and then our question and answer period. So just to begin with, a MAP program is a harm reduction program focused on alcohol, and it's about ministering alcohol beverages regularly, often along accommodations, but not necessarily, maybe some other programming, and that's to help prevent alcohol-related harms. So the objectives of a MAP program, so they were created to help reduce harms related to dependency of alcohol. And MAP participants are people who experience severe alcohol dependency. In many cases, other methods of treatment haven't worked for them, or maybe they're just not interested in that as well. So there's 3 categories of harm associated though with alcohol dependency that MAP is aiming to reduce. And so that one is the acute. So the injuries that happen, the poisoning, the immediate withdrawal effects because of heavy alcohol consumption and then not maybe having access to it and going into withdrawals. There's the chronic. So that is a range of different illnesses, the liver diseases, cancers, strokes, some gastrointestinal diseases, putting themselves at risk for potentially getting other like STIs because they are, under the influence all the time and maybe not making the best decisions. And then there's the social piece, which is the problems related to housing, relationships, employment, finances, crime, ending up, on the streets in Saskatchewan when it's winter, passed out from alcohol is very dangerous. So many of our MAP participants have experienced a range of harms related to alcohol use and alcohol withdrawal. And these harms are compounded when the majority of drinking is occurring in, dangerous situations like street settings, and where, back alleys, like I said, cold places. So this is some of the objectives. The goals around the planning, implementation, and continuity. And this includes, I've added the pandemic because I think we've seen a lot more managed alcohol programs spring up in the pandemic, and it's perhaps been a blessing in disguise in this area. So we work as an approach where at the beginning, in the middle, we're looking at supporting the wellness and the well-being of the client and really meeting them where they're at. And for every person, that's somewhere different. Part of what we're doing, our goals are to prevent the complications from severe alcohol use disorder and high-risk drinking. We're trying to maintain or reduce alcohol intake. By no means are we trying to get to abstinence. We are definitely a client-centered program. We want to create consistency so that we can prevent the withdrawals and the complications that come with withdrawals. We really, really are working hard in our community at trying to reduce or eliminate non-beverage alcohol consumption. So hand sanitizer, mouthwash, those are definitely dangerous. They cause other complications, but they're readily available. We want to promote safer use through harm reduction education. So for alcohol harm reduction, we recognize that abstinence is not achievable or even desired by some, or even appropriate for some people. So we want to help to address those acute, chronic, and social harms. And then during COVID-19, we have learned about kind of what's happened in our communities, and I'll talk a little bit more about that. But with a managed alcohol program, we can reduce the risk or maybe prevent COVID-19 infection and transmission, and then also support our clients if they end up in isolation, if they have suspected or confirmed COVID-19. Because as you can imagine, you can't go out and find a drink if you are isolated somewhere. And the principles of care for our program are around understanding that alcohol use disorder is chronic, it's relapsing, it's often the clients we work have been involved in this for a very long time. We're acknowledging and addressing the inequalities or inequities of the social determinants of health of many of our chronic alcohol drinkers. So things like housing, food security, access to health, trauma in the healthcare. We are incorporating harm reduction and using a trauma-informed lens. So really shifting how we see our clients, how we work with our clients, really working on safety, trust, humility, looking at those grandfather teachings and how we incorporate them with our work. We're incorporating Indigenous cultural safety and practice of cultural humility. This is something in our agency that we do. I do personally as a practitioner, is that self-reflection, but as an agency, how are we meeting these goals? Where are our clients at? How can we connect them with culture so that inclusion of cultural practices and design and provision to support their wellness? So bridging that cultural divide when requested, when we see a need. We're trying to provide a holistic and comprehensive care, and we provide referrals we need, and I'll share our team structure with you and all those involved. We involve family and social contacts in care planning when appropriate. As you can imagine, many of our participants don't necessarily have good family connections, but they do have good social connections amongst each other. And so we really focus and support on those connections that are important to them. We are a client-centered care approach, so we create care plans that are individually tailored, patient or client-centered, and adjust as needed. And our clients do have a big say in what happens and how we move forward. And we include our clients in that with lived experience in the design of our program. So we're always seeking input and finding better ways of providing services and reducing barriers, understanding also we have to, practice best practices and can't do anything harmful. So the types of programs that run across Turtle Island typically fall into one of these three categories. There are many, many examples of this. So residential programs are programs that have a shelter or housing component connected to their managed alcohol program. And a good portion of Canadian managed alcohol programs incorporate a residential piece into it. So whether it's you get your pours at a shelter or you're living in a supportive housing or a residential care facility. There's also non-residential based managed alcohol programs. So they're a standalone program. Often they might be known as an outreach program. So they're not associated specifically with housing, but they often only operate during daytime hours. They connect though clients to other services. They would be an access point for finding housing and social services that would meet managed alcohol client needs. And I know that out west for sure, they do have a peer developed managed alcohol program. So this is peers who are working together to support each other, and they manage their own alcohol and get support from services when needed. And then in some areas, not in ours, but in some areas, we have hospital-based managed alcohol programs. So they're established with medical professionals who will provide alcohol to patients while in hospital that can help facilitate their care. Hospital-based managed alcohol programs are often required with more intensive medical care, and the realization that detoxing from alcohol while they're in the hospital can be dangerous, and also knowing that they may go back to alcohol when they leave. So instead of cutting off the alcohol during that time frame, there are physicians who will work to keep patients using alcohol if it's appropriate for their care. I will say that the physicians in our area would be open to this. It would probably be other care providers in the hospital we would have a harder time convincing. Participants in hospital-based MAP programs are individually assessed to see if this is suitable for their care plan based on their medical needs as well. And sometimes those MAP programs in hospitals can be temporary for clients and not translate to a community program if it's not set up for that. And then during COVID, we've seen a lot of pop-up MAP programs for isolation, and I'll talk a little bit more about that in our province. So just for you, I heard someone say that they were from Toronto, the center of the universe. I'm in Saskatchewan, so the center of the prairies. There's the yellow rectangle. We're easy to draw and easy to find on the map. The Saskatchewan, we have 6 different treaty areas and 74 different First Nation communities. So looking closer, I am, let's see if I can move my mouse here. In the Battlefords are over here in Saskatchewan. So in the blue Treaty 6 zone, more to the west, northwest of Saskatoon. The Battlefords are where the Battle River, which many of the First Nations we work with live on, flows into the North Saskatchewan River. And we confuse a lot of people because we have a town of Battleford and a city, which is North Battleford. And we're separated by the North Saskatchewan River. And the town and the city have their own municipalities, and why we don't work together is beyond me, but I believe it has to do with our deep and rich history. So the town was established in 1975, and it was the capital of the Northwest Territories and home of the Northwest Mounted Police. There is a very rich history in that area, not all of it that great. North Battleford sprung up because the railroad decided to build on the north side of the river, and we became a city in 1913. So just a little background on why we have a difficult community to work in sometimes, although we're getting better. We have a very difficult history, and we feel those impacts still today. So part of our history is the hanging of 8 Indigenous men during the Northwest Rebellion here in Battleford. More recently, we are known for the Colton Bushi shooting that happened on our farm just outside one of our First Nation communities. Unfortunately, several years in a row, we hit #1 most dangerous city in Canada to live in Maclean's magazine. And W5 did a very interesting expose on our community, and we were dubbed Crime Town for quite some time. It's not all doom and gloom. In 2019, Justin Trudeau came out to Poundmaker First Nation, and Chief Poundmaker was officially exonerated as he was part of the integral steps of signing Treaty 6 and adding the medicine chest clause to the treaties. So that has been a very important piece towards reconciliation in our area. So North Battleford has about 15,000 people, and we're surrounded by 7 First Nations, maybe 8 if we extend it a little bit farther. About 25% of our population in the Battlefords is Indigenous, so Métis and/or First Nation. We run into a lot of racism, deep-rooted racism based on our history and our community. And so as a community, we are working on this. Our First Nation communities and municipalities signed a historic agreement, the Âciwina Relationship Agreement, to build government-to-government relations and work on racism and collaborate on things such as health. So we are trying to repair some of that past. This history is important because getting this program was difficult. We had a lot of backlash in the beginning, and I will say that this agreement that's happened between our communities and the government has helped pave the way to addressing some of the inequities in our community, and I think is helping us move forward in some areas like managed alcohol. So I work at Battle River Treaty 6 Health Center. We've been a health agency for 42 years. When they shut down our Indian hospital, the chiefs of the day came together and created our agency. We now service 4 First Nation communities, Lucky Man, Cree Nation, who doesn't have a land base that people live on, Powmaker First Nation, Little Pine First Nation, and Sweetgrass. Our agency has approximately 90 staff, and we run a variety of health programs. Most of them are based in our First Nation communities. And quick fun fact, we were the first First Nation health agency to be accredited by Accreditation Canada back in the 90s. We also have a really great working relationship with our local health authority, particularly in primary health. So together we co-run a primary healthcare site, a sexual health clinic, an opioid addictions recovery service program, and very soon we are in the process of developing a rapid access addictions medicine clinic that will be co-run by us and the health authority. The team that runs the managed alcohol program is my team, and I'm super proud of them. Our department is the wellness department. We're only 10 years old in our department, and we provide counseling on and off our communities, both for youth and adults. We do various outreach. I have a staff who is a hospital liaison for mental health. I have a youth transition worker who helps any of our youth on or off our communities who require services and may fall through the cracks. We have case managers for our opioid and managed alcohol programs for both on and off our communities. And I have the pleasure of having a cultural program with 2 cultural facilitators and 2 elders at my disposal, which I love, and they help guide our program. And our vision as an agency is to have engaged and holistic communities. And about 4 or 5 years ago, we adopted the 7 grandfather teachings in our agency to move forward and work in a better way. We had our elders come in and provide us teachings, and with that we also got input from staff and community to look at how do we demonstrate these in the workplace. And so when we started the managed alcohol program, we wanted to make sure the program fit into our values. So I'm just going to spend a little bit of time talking about how does our managed alcohol program meet these values in our agency and the teachings we've had from our elders. So the first one, Sagitwin, my Cree is not very good, I'm learning. So love. Love was demonstrated before this program even started. It was the reason we wanted to do more for our clients and created an opportunity to support them in their life journey. So this program really was developed out of the love for our people. We develop a lot of connections with our clients, and we hold each other accountable. They hold us accountable and we hold them accountable, and that's because of the love. So in this photo, you'll see myself and a couple of my staff. We took some of our MAP clients, and I think in one extra who wasn't on our MAP out. Unfortunately, we lost one of our MAP clients Thanksgiving weekend, and so the following weekend was his funeral, and the staff without even hesitation said, you know, can we come in on Saturday and borrow the work van to take people out to the funeral, because it was out in one of our First Nations not far from town. And I immediately said yes, we can. And so we went out there and spent the day with them, and as hard as it was so wonderful to see them support each other and the community support them. And of course, they were super excited to get some chicken on the way home, because they had only had soup and sandwiches, I think, for the last couple of weeks at the shelter. So Âciwina Respect. This program was developed with the respect of the client's needs and inputs. So this is a client-centered program. Each person that's involved is respected and their wishes are taken into account, assuming they fall into best practices. And our physicians, we have really great physicians that also work from a client-centered perspective. Wisdom, I'm sorry, my Cree teaching stopped. I only know 3 values right now really well. I have till Christmas to learn them all. That's my goal. So wisdom demonstrates the best practices that we use as a team in developing the program. So we worked collaboratively with another program and their successes. And we also worked with the community-based practice across Canada and learned from them and gained wisdom from our health authority as well. So we took all this wisdom to help support our clients. Courage, we did take a big step of courage in providing this program. We did it quietly. We didn't announce we were doing it because of potential backlash in the community, not really towards us, but towards our clients. And so we don't need to be loud about this. And we also took a step of courage in talking with our funders and really fighting for the needs of our clients. And I would say that our clients took the biggest step of courage as trying something new. Honesty, so delivering a managed alcohol program requires a lot of honest conversations with clients, with us, growing pains along the way, with the team. Physicians have very honest conversations with clients, and they have honest conversations with each other. Tapwewin, truth. In delivering a new program during this pandemic, we had to open ourselves up to learning a lot of hard truths about what works, what doesn't work. Ongoing responsiveness, evaluating what we're doing, learning from the clients, learning and trusting and finding the truth about partners and funders. All of that were lots of learnings for us. And then finally, humility. So humility is probably the biggest lesson that we've learned throughout this. Our clients have taken us in this short time on an amazing journey from the short time we've done this, and they have become family. We do not walk down the street without stopping for a handshake, or used to be hugs from our clients, and our kids know the clients from being around in the community, and so we've been really humbled by this experience. So here's quickly our timeline. I'll go into detail. So in 2018, we started developing some relationships with agencies. In 2019, we really had a vision of what we wanted our program to be. In 2020, we threw everything out the door because COVID came along. In 2021, just this year, we launched a small pilot map. And unfortunately, as of last week, we've had to suspend it, but I will speak more to that in a minute. So in 2019, the top picture there is our shelter. It's run by the Lighthouse. The Lighthouse also runs a shelter in Saskatoon, a larger shelter. And then the bottom picture is the backside of the building I'm in right now. It's one of the few buildings our agency runs out of in North Battleford, and then the rest of our staff work out in the clinics in the community. So in 2018, we sat down with the staff and leadership of the Lighthouse, and we were discussing with them some concerns clients were coming forward with. So since we're not directly involved with the shelter, clients feel very comfortable coming to us and asking for us to advocate on their part. And so we sat down and had some very honest conversations with the Lighthouse, and we weren't there just not to criticize them. These were concerns from clients, but we really wanted to work together towards dealing with some of those issues, but also how can we do better to work for our people. So we brought other agencies involved as well. Income assistance was very important. It probably is one of our biggest obstacles for many of our clients. We had the RCMP on board because they were frequent contacts with the RCMP. And also we had our city involved because we had downtown businesses and we needed to get them on board as well. So this relationship development was really the key to our program development. And I would say in your communities, if you're looking at how do we run, how can we go forward in this, really think about those partnerships and relationships you've been building, and you continually will build. It's definitely needed. It's worthwhile. It's why we were able to even do a program. So in 2019, we had been going through meetings and we decided we wanted to work on a managed alcohol program. We had a core group of folks who really could use it because of their health issues, their access into ER, what our physicians were telling us. So we were going to run a managed alcohol program similar to the one they had in Saskatoon. We were going to go off a residential program, so have a standalone place where people could have a safe home, live together, and also receive alcohol pours in a safe place. We wrote proposals. We tried to get the involvement of our local health authority to help us deliver the program and fund it. They were not willing to go there yet, despite being the funders of the program in Saskatoon, so just an hour and a half southeast of us. So we tried, we did a lot of work. We did get some program dollars. They weren't substantial. As you can imagine, a residential program requires 24/7 staff. And so it just wasn't working out how we had planned. And but we were still patient, and we were putting together proposals and looking at the research and looking at numbers and getting as much stats as we could locally. So we were doing all of that groundwork, which sometimes is long, and this is where my patience comes into play, because I kind of just wanted to start a program right there and then. So that was happening through 2019 and 2020. The beginning of 2020, we actually visited the program in Saskatoon, and on the cusp of being shut down in the world, we were in Edmonton visiting their managed alcohol programs there and learning more from them and how they ran theirs. Literally, the day we came back from Edmonton, everything shut down, our province shut down, and lo and behold, we were in a pandemic. So the pandemic disrupted clients' access to alcohol, to housing and support. We've seen increased complications in our ER and on the streets. We've seen people using more hand sanitizer, so non-beverage alcohol. In 2020, our health authority in our province started a managed alcohol program up north. So in La Loche area, this was our first provincial COVID outbreak, and it was hitting those communities quite hard. That area is also very well known for a lot of different social impacts and a lot of alcohol addiction, and the liquor stores were being closed. And so they wanted to circumvent withdrawals flooding the healthcare system during COVID. And so they went up there, learned from us, learned from what we had learned from other areas in BC and Ontario, created some work standards and processes, and went up there and they delivered a managed alcohol program. And then when they kind of were settled down there and they left, so it wasn't a long-standing program, when they left and the liquor stores opened again, then that program disappeared. But that model of supporting clients in isolation hotels started up in our area, and my team jumped on board immediately. We wanted to partner with the program. We wanted to learn from them how they did assessments. A lot of the folks who were going into the isolation hotel were known to us, so a further place to develop programs. And through this, by the end of 2020, we were talking with the Lighthouse again about moving to a shelter-based managed alcohol program and what that might look like, using our current staff and a little bit of additional funding from a shelter staff. And we did get some funds to purchase alcohol. So COVID was an opportunity for us to get going without very limited barriers. From not many people said no to us. And the Lighthouse at this time had also started developing a similar shelter model to meet the needs of their clients in their area during the pandemic. So they had already been working on this, and so we took that and scaled it to our area. So in February of 2021, we launched our pilot MAP program. We did this with the support of our physicians and our case manager in our opioid addictions program. So we housed it in that program because our physicians have specific addictions hours assigned to them that they can bill, which is beyond my comprehension, but we were able to access physician time there. And the shelter staff, they were able to hire one more shelter staff to support that. And so we started with 5 clients. We were very strategic in who would be in our pilot. Of course, we had to screen them. Alcohol had to be their addiction of choice. They were heavy drinkers and often users of non-beverage alcohol. And also what was really important was a group that would work together, that would support each other, that they didn't have any issues out on the street that we knew of that would become a barrier, because we didn't have a lot of space for people. So here's my beautiful team. They helped make this magic all happen. In the top left-hand corner is Jessica. She's the supervisor of the program. Next to her is Jenny. She's one of our elders. And then we have Emily in the top right-hand corner. She's our case manager for our opioid program who took this on. And then after February, we hired on Kristen, who's below her. She's another case manager for our opioid program, but she works on communities and also takes on the MAP program. Below her is Karen. She is our liaison staff. She's a gem. She knows every one of these people inside and out. She works on the ground every day with them. Next to her is Noel. He's another one of our elders. And then we have Sherry. She's a casual staff with us. She's been helpful in supporting the team. And above her is Lori. She is the youth transition worker who during the pandemic, her caseload slowed down a bit. And so joined, and they do all the heavy lifting of the team. They write the work, all the policies involved in it. They know the clients in and out. I'm just the one who looks for the money for them. And so I'm very proud of the work that they do and my team that have accomplished. Now, I don't have pictures of the shelter staff, but definitely they are an important part of this team, as are our physicians who we consult with ongoingly. So our shelter-based program was started. We partnering, and it was essential for us to partner. We don't work 7 days a week, 24 hours a day, so we needed that partnership to move forward. We had 5 clients max that we could handle, that our physicians could handle, that our case managers can handle. They signed an agreement to join the program. They were all told what it was about. They spent a lot of time educating them about the program. They also signed consent to release information so we could collect data. We borrowed standards of practice from the Health Authority and the Saskatoon program. We adopted them for our areas. The case manager did training of staff, was trained from staff in the Health Authority and the Lighthouse. Pours happen 4 times a day at the shelter. So at 9 o'clock in the morning, 1 p.m., 5 p.m., and 9 p.m. And that was picked with our physicians, with the clients, and with the staff at the shelter on how we could minimize withdrawal and also minimize how big of pours we do for people. All the clients were assessed before pours for withdrawal and or intoxication. If any clients were experiencing withdrawals, especially in that morning pour, our case manager was there every morning, Monday to Friday, to assess them. If they were experiencing withdrawal, we worked with the physician on the dosing for the last pour. If they were intoxicated, either from our pour or because they were going outside to get their own drink, they didn't get their pour. And if you can imagine, sometimes when they're intoxicated, they're very insistent that they need their pour. So we also introduced non-alcoholic beer we would give to them at those times, just to diffuse the situation immediately, and they were very agreeable to taking it. They didn't know it was non-alcoholic beer, but it helped just alleviate some issues in the shelter because there's other clients at the shelter there who weren't on the program. So for the first month, our case manager was there at every first pour. She was checking for all that needed to be checked. She did all the intake. She did all the screening, the prediction of alcohol withdrawal, worked closely with the physicians, worked on client agreements. We were trying to get clients to move to trusteeship. So in our program, we wanted to get the clients on a trustee, which also meant they would be connected to income assistance because not all of them were, to help manage their funds, because eventually we were moving to a cost share alcohol program with them. But in the beginning, the alcohol was purchased and we had enough to get us till the end of March. And so no clients needed to pay for anything as we were sorting out their finances. All the participants worked with our physicians to get a full medical and lab work done, and they did so ongoingly every month or as needed if not something came up sooner. The team met daily to work out any issues that came up because we were learning on the fly. And all of our paperwork is kept on an electronic health record. So that includes all of our pours, whether they were there for a pour of alcohol or whether they weren't, so that it could be tracked if any issues came up, and the physicians would have access to that info if one of the clients showed up in the hospital. What else can I tell you? Our program was done in the shelter. We had a room. It wasn't the best space, but we were willing to work with it, and the clients were also on board with it. So some of our client challenges that have come up, interesting enough, warm weather. If you can imagine, we started this during cold months. In Saskatchewan, February is very cold. So we had excellent attendance at our program during that time. Once it warmed up, people tended to go out, they got drinks on their own, they started to use more non-beverage alcohol. And so consistency then changed. The price of alcohol, so when we move towards a cost share, alcohol is very expensive, hence the reason this program is expensive to run. The assistance that clients get in Saskatchewan is not enough to cover all their alcohol, and they typically don't have any money left over for their other needs that they have. So we have moved towards fully funding the alcohol. This is one of our working with our clients and seeing what's not working. This wasn't working, so we've made that change. How do we fund the alcohol? We take in donations of alcohol. We get, if we get, I do different suicide intervention training, and if we make any money on that, we put it towards our alcohol purchases. And we've used some of our COVID funding to purchase alcohol. And we're working towards working with our funders as purchasing alcohol as part of a harm reduction tool. It's not necessarily recognized by that as by our funders, but it definitely is a tool for our managed alcohol program. And then then the challenge came was consistent attendance when the summer months came. So we were having issues with this. And so we developed an incentive program. The clients really wanted to earn coffee outside the shelter. So if they attended 18 out of 28 pours in a week, they would earn a gift card for coffee at their favorite coffee place. And they were very happy. They loved that incentive program. We had one client who, the week that he met it, he was so excited that he met his goal, and they were all supportive as a team in that. So some of the system challenges we have are supports from other potential partners like the health authority. We're really trying to get them on board to help fund us and help run the program, but we aren't quite there yet. Social assistance can be very challenging. It is a difficult system for people to navigate, and the amount of money they get does not cover alcohol. So that became a challenge for us. Funding and funders. So sometimes people don't like to fund alcohol. And so we're working on this. I don't think it's new news anymore. And so we are moving forward and hope no one does any big audits on us because we are purchasing some alcohol with our funds. Our own process became a barrier. So having a trustee was a barrier for some clients. So we are changing our agreements right now. We're reviewing our processes and trying to decrease barriers for clients. And it was also really hard to find people who would be trustees. The space, I said, was tight. The clients had to stay there while they were drinking their drink, and they couldn't go to other places. And so it just, it would be nice to have a little bit homier space, but we will, get to that hopefully one day. And then, man, one of my biggest challenges is getting data. Despite having consent forms signed by clients, police, hospital, ambulance are not readily releasing data from us. Actually, they're just not really getting back to us at all. And I get we're in a pandemic. So that's been a challenge. For us, our biggest success is our client connection, their connection with each other. They created accountability among each other. They supported each other. Our one woman in the program kept them all accountable and, was giving them little lectures if they didn't show up for pours. But the clients kept our staff accountable as well. If they were 5 minutes late for a pour, they'd be looking at their clock saying, oh, our pour's 5 minutes ago, and holding each other accountable in that way. They also had an opportunity to be connected multiple times a day, and they felt less alone. And our staff then also had eyes on them and could go out and search if we didn't see them for a day or so. We definitely, our success was our teamwork within our agency and with the shelter staff and the medical field. It really has been a great team connection. We had a decrease in ER visits. We know this because our physician who works ER and is in our managed alcohol program told us that one of our clients who used to, in the cold month that we started and he got on the program, he would visit ER almost daily, if not twice daily, because of withdrawals and seizures. And after a month on our program, I think he'd only been to ER 2 times. Unfortunately, when it got warm out, he was out drinking other alcohol, and he probably was in ER more, but still less than when he wasn't on the program. They all started accessing and following their own health needs. They created some goals for themselves. So they wanted to get their vision taken care of or their dental. They were all connected through on their income assistance programs. They also took the opportunity, now that they were stabilized, to connect with counseling, something that they hadn't really done before. And so they were one-on-one coming to seek our staff here at we only are 2 blocks away from the shelter. So they would come here and see our counselors and connect with our elders here. And then through this program also, we had clients who voluntarily reduced their alcohol use, still maintaining safe levels. And they did this in consultation with their physician. And they have a beautiful relationship with their primary care doctor. So I see we're almost up in time, but recently, present day, as of last week, we have suspended our program. Our shelter at the end of September was taken over by another agency. We don't have the same partnership with that agency. They're on a very big learning curve. And at this time, we aren't able to go in there and deliver the program. And we can't do it all alone. We do really require that partnership. So we consulted with our physicians, we consulted with our clients, and we've discontinued the program for now. Also, at this time, I think we would only have 2 people on the program. Unfortunately, in the last month, we've lost 2 of our managed alcohol program clients, one to exposure and another one, well, her liver was shutting down. We knew this a while ago, so. It has been a tough ride for our people and for my staff in the last little while, especially with this suspended program. It's been really hard on our staff. So we do have some future goals. We're looking at a new partnership. We have a residential program who is looking at what we've been doing and seeing The success, one of our clients moved from the shelter to that program, and they've seen kind of how it's impacted him in a good way. And so we're looking at partnering with them and delivering that program through a residential, it's a low barrier residential place. We're still open to partnering with the shelter when they are ready for that. And we're also looking at how maybe we can move into an outreach program. We do have some people out in our communities that might benefit from a managed alcohol program, but of course, we do need the okay from the community and leadership. And so this is where we're at present day. It was a very difficult conversation last week, but we are hopeful in moving forward. I'm not ready to give up. We have worked very hard to get where we are in our small little community. So that's it. I'm open for questions.
Okay, thank you so much, José. That was such a fantastic presentation. I think you really, with honesty and courage, outlined the process and the challenges and the successes. And just my initial thought was just the successes you've outlined are so important and such great work. I'm really hopeful that things can get back off the ground and doing that good work again. I'm happy to write a strongly worded letter to whoever you want me to. But honestly, it's such good work. So there's some questions that I can from the audience I can ask. If anyone else has questions, please type them in the chat now, and I'll ask you them. So the first question, I don't know if you'll be able to answer this one, maybe others will be able to answer as well. Are there MAP programs available on any reserves that you're aware of?
Well, you know, I'm aware of Port Hardy. They have an outreach program and they work on and off reserve. They do I believe they do 2 alcohol drops a day. So in the morning and in the evening. And they have nurses and outreach staff who deliver that program. So that's what I'm most familiar of. I went to a rural MAP program discussion and there's not a lot of us. And so also it depends on the leadership of the community, whether they want alcohol brought into their community. I think that's part of the challenges. And there might be others that I don't know about. So someone out there might have an answer better than mine. Oh, we lost your, I can't hear you all of a sudden.
I double
There we go.
myself there. Okay. What happens when an individual quits cold turkey and also quits smoking at the same time? Have you had any experience with that?
Well, I don't know anyone who's quit smoking. I know that if people want to quit drinking cold turkey, we want to connect them with our physician. There's medication they can be given so they don't go into withdrawal. But quitting drinking cold turkey is very dangerous depending on how long they've been using and how much they've been using. So it's not something that we recommend without consulting with their physician.
Awesome. Chantel asks, so to clarify, how long do you do the reduced pours, and do you eventually just pour non-alcoholic beverages to pouring tea, juice, water? I'm interested in how long this program normally takes to help reduce or eliminate alcohol consumption.
Okay, so our goal is not to reduce or eliminate consumption. It's to work with the clients that are at where they're at. So the clients themselves will come to us and ask if they want to reduce their intake. So our one client who was having liver failure still wanted to drink alcohol, but at a reduced rate. So in consultation with her, I mean, that's where our physicians come into play because they have all the medical knowledge of how their liver is working and how it's going to affect them. And so they work together. The reason we use non-beverage alcohol is often when people are intoxicated and we can't give them further alcohol. Our goal isn't to have a bunch of intoxicated people, it's to avoid withdrawal and keep people kind of at a happy homeostasis level. And so if they come already intoxicated, we provide non-beverage or non-alcoholic beer to avoid fights really in the shelter because they can get a little unruly, and the staff just have an easier way of supporting them and they feel like they're getting their pour. Definitely, we will work with clients if they want to reduce that, and they can go to not to abstinence if they choose to do that. And a lot of programs, people do choose that. In ours, we hadn't experienced that.
Okay, awesome. I think that really embodies the spirit of harm reduction, right? Your answer there. What was the biggest challenge you had in starting up the MAP program?
People, ideas and attitudes around giving people alcohol, much like other harm reduction programs, but some of those we're not providing people with their drug of choice. We're providing them with tools in managed, at least in our area, in a managed alcohol program, we are giving them alcohol, and it's a really big mind shift for folks. And so we actually started these conversations much before 2018 because a lot of our local downtown businesses were noticing rubbing alcohol, mouthwash, all these things being stolen or other items stolen and traded for money for alcohol. And so we talked about this concept and they just really couldn't wrap their brain around it. I think once people seen the difference this is made, we are slowly getting people on board, but it really is a mind shift. The agency that's taken over the shelter isn't there yet in their mind shift, hence the reason why we have to stop our program. And so that for me has been our biggest challenge.
Awesome, thank you. I guess just my own question to follow up on that one. I imagine there's lots of potential for conflict for abstinence-based programs or the ideologies of some of those kind of approaches. Are there strategies in kind of negotiating or educating people about harm reduction that you found helpful?
Well, sometimes people like to see the stats, and so we'll show them all the evidence that is out there. There's lots of evidence in this practice. There can be more. We've seen when it comes to a political-based piece where money's an object, we've shown the financial savings of a managed alcohol program. And, at the end of the day, appealing to people's, love in their heart for folks. But it's just constant education, looking at what harm reduction is. As an agency, we have a managed alcohol program and we also run a treatment program. And so we have to, though, because we have to meet people at where they're at. And so I think it's a big shift for people, but we're getting there slowly as more information comes out and becomes more accessible.
Awesome. One of the things that really stood out for me was kind of like the holistic wraparound approach you take to addressing help with finances and physical health care and all those things. That sounded so good. Someone asked, do you foresee any opportunity or potential to publish this whole story, the successes and the challenges, maybe even in an academic journal? Have you thought about it?
I haven't thought about it, but now I have. I will keep that on my radar. We are I'm going to say we are just off the cusp of finding out that we really have to shut down this program. And so we're all still dealing with the shock of that. And plus we just lost two in the last 3 weeks, two of our clients. And so it's been, we're healing, we're in our healing right now of this. But definitely we want to move forward and we'd love to connect with the university if we can get going. And because a smaller program has different challenges than in a larger city, we don't get the numbers or the funding necessarily. And so we have to be creative.
Absolutely. It sounds like your small team has just done a ton of work. It's pretty impressive. As a First Nation community, would we be able to contact you to share information as we're starting a new opioid program and we now want to include a MAP service? Would you be cool with that?
Yes, I am. I'm going to put in chat my email address, which is the best way to get a hold of me because I never answer my phone because I'm never in my office. So I sent that to everyone. Hopefully that popped up. That's my email address for sure. Connect. I know one of my colleagues towards the end of the month, I think, is talking about our opioid program and how that program really also paved the way to get our physicians and our team on board for this program. We're very lucky in the physicians we have in this area. I will say that.
Awesome. Has there been experiences with overdose at the program?
Yeah, I mean, we have overdoses from other drugs, and we've done a lot of naloxone training in the area. And then we have more so with managed alcohol, we see a lot of seizures. So when people come for their drink and then they go out and find their own drink and they overdo it, or they're withdrawing because they haven't come to the program for a while and they haven't been able to get any alcohol. And then it's not uncommon for my staff to find them. We know the places where they are, and we've many times had to send them in an ambulance because of withdrawals and seizures.
That's tough, and so complex supports.
Yeah.
We have a question about the use of natural medicines with the clients and the incorporation of cultural practices with elders.
So we, our elders visit our program ongoingly, and clients come here and seek our elders and our cultural facilitators. And some of them have reached out for natural medicines. That's not my area, and they work together. Part of that is the different elders, how they work and where people are in their addiction and sobriety and what things they can do while they're still under the influence. We have very kind, gentle elders who will spend time and take them. We have a cultural room here where they smudge and pray together. And so part of that is also meeting where our clients are at. A lot of our clients feel a lot of shame around their culture because of their use. And so we're very gentle, and we go with where they're at in meeting those needs.
Awesome. If the client's drug of choice is supposed to be alcohol, how over time do you know they're not using anything else? And if they are they still able to attend the program? For example, if they're using benzodiazepines or opiates as well?
Yeah. So we don't until they go see the doctor, if the doctor happens to do a drug screen on them. But we still have them in the program as long as alcohol is still their main. Most of them really is alcohol, or they smoke pot as well, are the two main things. So we haven't had a real long time with this program. Some of them have dabbled in other drugs and don't like them. But they're fairly honest with us, and we don't, it takes a lot to get discharged from our program. We are a very low barrier program. Yeah.
Oh, that's great. How do you provide service to pregnant women? And a related question, how do you provide support for a mom who's with child?
So we haven't had that experience. Our folks in the shelter were not pregnant, and I guess we would cross that barrier when we came to it. We do provide services to pregnant women in our opioid recovery program, and so our physicians follow the standards of practice for that. All of our clients were living in a shelter, and the shelter that we have in ours is not family friendly, and so we had no parents. Well, that's a lie. We had parents, but they weren't directly connected with their children. They weren't staying with them. Most of them are quite estranged from their families, actually.
Okay, thanks for that. I just had another question about connecting with you and sharing resources and joining community practice. So I'm just going to copy paste your email in again.
Perfect.
You get a barrage of emails, but that's a good thing. We've got lots of people saying thank you for running this program. There was lots of condolences for the losses to the community. You go girl is in there. Lots of chi miigwetches for your work. I don't know if anyone has any final questions. You can put them in the chat. We have a few more minutes before we close up. Okay, so while we're waiting to see if there's any final questions, Kathleen's going to put the evaluation in the chat. Please complete that. We want to learn We want to learn from each of you. And I just want to say a massive chimigwich to you, Jose. Such an awesome presentation and such important work. And I can just see you rolling with the punches and all the challenges that come with funding and people's perspectives on harm reduction and that. And it's such good work. And I can tell that you'll be back at it and things will be up and running again, because you seem like the kind of person who doesn't kind of take no for an answer. So that'll be good. All right, so lots of good resources shared in the chat. Our evaluation is in there, and we also have next week's webinar, which will be Dr. Brenda Rastool. We're starting an hour earlier next week, so remember, if you're registering, we're starting at 10 Eastern Standard Time rather than 11, so don't miss it by getting the time wrong. Yes, and someone's saying thanks so much about being open for this discussion and all the challenges and biases, meeting people where they're at. I think that was such a good name for your presentation. Oh, I should probably share my screen again.